Assalamu alaikum and Bismillah ar-Rahman ar-Rahim. Welcome to I believe this is the 12th Tabadlab Policy Roundtable. And today, for the first time, we're doing a roundtable that is rooted in a working paper that Tabadlab has published. This is, of course, our most recent paper on achieving 21st century, reformed 21st century public health systems and the struggle and the ideation and delivery of a universal health coverage for Pakistan. We've got a fantastic panel. We've got people from different parts of the world who are working on different public health systems and trying to address the best way possible, not only to deal with the current crisis of COVID-19, but also the implications of that crisis. And in the Muslim world in particular, perhaps there's nothing so stark or jarring as the concept of the Hajj being restricted, which of course this year it will be. Hajj is coming up within the next couple of weeks, and at least for the first time in my relatively short or long, depending on how old you are, life, this is the first occasion on which there are serious restrictions and constraints to the participation in the Hajj. We're joined by, as I said, a fantastic panel. We have Dr. Dilshad Ali bin Abbas Ali, who is the Chief Executive Officer of the Makkah Healthcare Cluster, the Ministry of Health in Saudi Arabia. He's also served as the Executive Director of the Vietnam Healthcare Forum. We've got Zena Khoury Stevens, who's the Chief Clinical Executive at Clemenceau Medical Center in Dubai, and she was previously at Johns Hopkins Aramco Healthcare, where she oversaw nursing and clinical services. She's been instrumental in helping develop a doctorate of nursing in the Kingdom of Saudi Arabia. We've got Stephen J. Thompson, who's the principal at North Star Healthcare Advisors, an advisory and consulting firm that provides health services in the areas of international healthcare and strategic planning at the systems level. He's got a wealth of experience. He's also the former CEO of the Johns Hopkins Medical International. We're lucky to be joined today also by Dr. Sara Saeed Khurram, who's the CEO and co-founder of Sehat Kahani, which is a startup based here in Pakistan, where we are as well. And this startup aims to democratize healthcare by building an all-female health provider network to deliver quality healthcare solutions using telehealth. Finally, and perhaps for me at least most importantly, we're lucky to have Dr. Muhammad Ali Chaudhry, who is a senior fellow at the Tabadlab for Public Health. He's the healthcare executive that's behind Emerging Health International. And most importantly for today's discussion, he's the author of the paper along with Amara Khan, shaping a 21st century public health agenda. So without much further ado, I wanted to just jump right in, and starting with this theme of the Hajj. Dr. Dilshad, you of course are at the center of the action in a way that I think many of us never imagined. The best that I can recall from the data, there's only going to be 1,000 Hajis this year. Even that is wrought with all kinds of risks. Just walk us through what the process has been like, how difficult the decision making on something like this has been, and how hard the preparations have been, and whether or not you anticipate, inshallah, great success in your very important, and as a Muslim for me, very intense endeavors.
Bismillah ar-Rahman ar-Rahim. Good afternoon to everyone. Thank you, first of all, Musharraf and the team at Tabadlab for getting me onto the roundtable today. And of course, congratulations to Dr. Muhammad Ali Chaudhry and Amara and their paper regarding universal healthcare. Well, I think in terms of the question whether how hard it's going to be or whether it's going to be difficult for us to run Hajj with this kind of situation with the pandemic, the Kingdom of Saudi Arabia, I think, has responded really well in terms of how their COVID response has been planned. In fact, in February itself, the Kingdom had looked at several measures, looking at the whole global situation, and in fact already prepared itself for an impending outbreak or pandemic within the Kingdom itself. The thing is that all throughout the last 4 months that we've been responding, or 5 months that we've been responding to the pandemic in Saudi Arabia. There has been intense planning, there has been intense capacity building, and it's also been swift responses to react to changes while the pandemic was progressing. Alhamdulillah, we've obviously seen surges. Of course, obviously also responded to the surges pretty well. We've kept our hospital beds in check, the ICU beds ready for any eventuality of patients increasing in number. With specific, relations to Hajj, yes, it is a little bit of a phenomenon, which is a big change in terms of how Hajj itself is proposed to be held this year, in line with what's going on globally and, of course, in Saudi Arabia as well. With regards to the difficulty, I think we've been planning this for some time now, anticipating that it is not going to be a normal scenario when it comes to Hajj this year. So in terms of number of people, we're still being officially informed that the number of pilgrims that are to come up to 10,000 still anticipated. Of course, the final number would be announced in the next coming days. In terms of preparations, all our hospitals are ready. We've been on alert for some weeks now. Mobilization of staff and, of course, the infrastructure and the equipment and requirements for us to contain the Hajj in safe means and also still manage the pandemic are pretty much very secure. And we don't feel there's going to be any kind of untoward response or incident with regards to how we run Hajj. The only thing that we basically would be paying attention to this time would be, of course, tightening up the infection control, ensuring that the Hajis or the pilgrims who come in for the pilgrimage this time are secure. We keep them well controlled within environments where the cross-infection and cross-transmission is minimized to as little as possible. And of course, always keeping the religious site secure in making sure that accessibility is controlled and, of course, movement is limited to avoid any kind of outbreaks in a mass gathering of this kind.
It's having performed myself, the imagination really struggles in terms of limiting the intimacy of people. Obviously, restricting that number to 1,000 or 10,000 obviously will help greatly. But in terms of the logistics, it suddenly seems that public health experts like yourself and Dr. Chaudhry and others in this call, public health experts now also have to become, in a sense, social architects and social engineers. They have to work closely with urban planners. They have to work closely with economists. How do you see this playing out in Saudi Arabia itself, where thankfully, because of government resources, the challenge may not necessarily always be a resource-based one, but it may be that public policy itself, like it does anywhere, struggles to coordinate in a way that is capable of catering to the urgency of the issue at any given point in time. Have you found that to be a challenge, and how has the system dealt with that complexity?
I think with regards to public policy, of course, from a regulatory perspective here, you do see that globally, there are, of course, it's very different when you look at corporate and when you look at how public policy works in terms of managing anything. With regards to how Saudi Arabia has worked in terms of Hajj specifically, and of course, managing the pandemic for COVID-19, there has been extreme flexibility in terms of how resources have been deployed, interagency coordination has been taking place, and in fact, His Highness the King, King Salman bin Abdulaziz, had made it very clear in the beginning of the pandemic that no barriers should be raised or any kind of restrictions be imposed in terms of giving a maximal response that would basically look after patients and take care of the pandemic in a positive way. So I think it's situational. As you said, a lot of public health providers and a lot of public policy makers would basically have to look at how flexibility would be a major part of how they respond. The Kingdom of Saudi Arabia has worked very, very well. Makkah especially is very used to an annual pilgrimage, and of course with the Vision 2030, we intend to increase the number of pilgrims to 30 million per year, which are Hajis and of course people who come for Umrah. So the response was still very much a disaster response mechanism with very good forward planning. There was a lot of modeling being done in terms of how we anticipate surges and capacity buildups that were required for us to cater for those increased numbers. And alhamdulillah, I think the whole response was managed pretty seamlessly across the board with excellent coordination on the ground and of course very good central command which cascaded onto the ground for us to look at a very positive impact in terms of how we've run so far.
So Zaina, you're based in the Middle East, and I've personally sort of seen the evolution there. I think a lot of us have over the last 2 decades, especially in the UAE, and for me in particular, I have a weird kind of romance with Dubai. I think so many of us do. How is this pandemic creating a conversation, if at all it is, about what needs to happen in terms of public health systems and their capacitation? One of the challenges in the Middle East, of course, has been that not everybody has equal access to the best healthcare facilities. In terms of the public health system, I know enormous resources have been invested, especially in the UAE, to build up the public health infrastructure so that private institutions like yours, while they continue to cater to those that can afford it, but the ordinary citizen, and particularly in the Middle East, the laborers and the low end sort of spectrum of skills also has access to the best healthcare. Has the pandemic triggered any kind of a discussion or debate that deepens that resolve, or has it overtaken everything so that we're still in kind of a emergency situation? Zaina, you'll have to unmute your mic before you speak. You'll have to start again.
Okay, sorry. Thanks for having me, and good afternoon, everybody. The pandemic definitely has highlighted a lot of things, and a lot of things that just Dubai is no different than everywhere else. And it was built, like you just said, with public and private sectors, right? And the public sector is built to help low socioeconomic or workers or any, Dubai thrives itself on expats, and there's expats that are from all parts of the world. So we quickly figured out during the pandemic that the public sector is not going to be enough. So the private hospitals were called to help. The government, however, was very good about streamlining all of those and designated a couple of hospitals to continue to be non-COVID hospitals, and the rest, whether you were public or private, you were treated the same, and you had to accept everybody and deal with billing and insurance and coverages at a later stage. So yes, everybody got equal healthcare and got access to both public and private hospitals if they were COVID designated. And what made you designated to be COVID is your resources. If you had the resources to take care of these patients and help in the pandemic, you were called upon to do so. If not, you were safe to be a sort of non-COVID hospitals and deal with other patients that continued to get sick, but not necessarily COVID patients. That has worked really well, and we quickly decided on that. As well as we were called upon to staff hotels, for example, and staff field hospitals. So if you can't bring the patients to your hospital for that resource, you use your resources to sort of resource out and outsource and support Dubai Health Authority hospitals. And all of that was done through one central command center, which really helped a lot. So that central command center oversaw not only government hospitals, but private hospitals. So everybody was pulled together.
Was that, sorry to interrupt, but was that command center? Yeah, sorry to interrupt, but was that command center rooted in Abu Dhabi? And was it a federal function, or was it at the emirate level?
So there were two of them. There was a Hajj command center, which was based in Abu Dhabi for the Southern Emirates. And then the Northern Emirates, it was based in Dubai, and it was through Dubai Health Authority. So there were two command centers. Worked very much alike, but the demographics are a little different. The patient population is a little different between Abu Dhabi and Dubai. So it served a purpose to have two separate ones to cater to the exact needs of the population. So you had more locals that were in Abu Dhabi, for example, that had different needs than if you were in Dubai.
Fantastic. And so just to go back to the question about sort of universal healthcare coverage, which is really kind of the topic. And obviously, I want Dr. Chaudhary to speak in more detail. But a lot goes into universal healthcare coverage, and from the standpoint of somebody who's helped engineer and architect a system-wide approach for nursing, for example, do you see any challenges outside of the resources? Because I'm about to take this conversation to Dr. Sara Saeed, and I think here in Pakistan, it isn't usually the resource. It is in fact the resources that's a constraint, in addition to many others. But I suspect that in the GCC as well, despite being relatively resource rich, there are public policy challenges that limit the effectiveness or the ambition of universities.
Yeah. You're breaking up, but...
Did you catch all of that? I'm sorry.
I think I lost the last piece of it, but I think the answer is yes, we are resource rich, but may start to be, but a little fragmented. So I think the key is not to just be resource rich, but to also pull the resources together to serve the population you're serving, depending on where you are. The UAE is still a little fragmented in that, and universal healthcare is not something that we do. It's a lot more insurance governed. Yes, everybody's insured, but it's private insurances. And there are some government insurances, but it's not readily available for everyone. So it is very much insurance driven. So it's not towards a universal healthcare. However, the resources are there. They're still a little fragmented, but there are some initiatives to pull them together. For example, where I work now, which is Dubai Healthcare City, was built for that purpose, was built to make sure that healthcare is standardized, at least in the region where you have DHCC hospitals. So there are efforts towards that, but I don't think we're there yet. We just need to pool our resources and not be fragmented. You can find a great physician, a great group of physicians, but not necessarily the rest of the hospital is great, and vice versa. So it's still a work in progress as it goes through universal.
No, I think that's really helpful. If we could just, Zena, if I could ask you to just mute your mic again. And I want to just quickly take these points to Dr. Sara. Dr. Sara, we have in Pakistan, of course, a really intense debate about this fragmentation issue. And we tend to call it the 18th Amendment. There's a lot around the NCOC. A couple of the questions I asked Zena were, of course, inspired by what we've been seeing here in Pakistan. Being relatively closer to the action than someone like myself, Dr. Sara, talk to us a little bit about how much of the conversation right now within the public sector is geared towards lesson learning from the pandemic that leads to the kind of support and enabling ecosystem that startups like yours need, but more widely that ends up delivering universal healthcare. And again, my question, when I say universal healthcare coverage, I'm not sure that necessarily means that the public sector is paying for every single person, or that there aren't private players, or there isn't insurance. I think all of those are bits and pieces, but bringing it all together requires a less fragmented system, whether it's Saudi Arabia or it's the UAE or it's Pakistan. Talk to us a little bit about where this conversation is here in Pakistan. And just unmute yourself before you speak, please.
Yeah. No, thank you, Musharraf. I think Pakistan, as all countries, has learned from the pandemic, and I am a positive person, so I'll say we have learned quite a lot in these last 6 months, and that's really going to pay off now. So I think when the pandemic happened in the country, initially there were a few hiccups where there was lack of quarantine of the people who were traveling in Pakistan, and then there was an initiation of a nationwide lockdown where we saw that there was, because of the 18th Amendment, there was a political split between provinces and the federal. And we saw some resistance between the both in being able to measure the lockdown to its fullest potential. The province that I am in, Sindh, had a very, very serious extended lockdown, whereas the other provinces did not. And because of that, when the lockdown was ended, because it was causing political and economic issues, we saw a rise in cases. And we had a peak of 15, 20 days a month before, which has started to now lessen down, and we anticipate another peak after Eid al-Adha. So there has been a problem in communication between the provinces and the federal, but I do believe that some of these strategies that have taken course due to our learning from pandemic will be very helpful. For example, from a full lockdown, we've now gone into a smart lockdown policy, which is being implemented all through our provinces and in the federal as well. One thing that I think the government or the public healthcare sector in Pakistan needs to learn from this pandemic is the value of public-private partnerships. Healthcare in Pakistan is already pretty fragmented. We already are behind all the national health indicators. We're not doing very well in maternal child healthcare, infectious diseases, non-communicable diseases as it is, with polio and TB as well. So new pandemic just adds more pressure into the system. And when a lot of people in the country pay out of pocket almost 80% for their expenses, I think this is the right time to now initiate and actually commence public-private partnerships that can have more people investing in the private sector in the company in order to build this sector, because we've seen time and again that public healthcare infrastructure is not able to manage the gap that is there in access to healthcare. And I think the gap is there with resources, with capacity building of resources, with infrastructure, with equipment being available. But one thing that startup like me has realized in this country is, because we've had the opportunity to work with the government of Pakistan as a telemedicine provider for the federal as well as the provincial government. So this is the right time as any to commence with a public-private partnership. And if we can have more of those in different sectors, as I already mentioned, that can be a real lesson going forward and can really build the healthcare system for all sorts of problems that are going to come our way even after the pandemic is over.
So, I think this public-private partnership thing, I kind of come from a place where I'm naturally skeptical of the private sector. So, I want to come back to you on this as well, but I wanted to take the conversation over to Stephen Thompson. Stephen, when I sent around the notice of this conversation, people saw that Dr. Sara and yourself were on the panel, and they were like, so basically you're now basically promoting the private sector in a country where so many people are without health care, and basically you want these big venture cap firms and these big startups, if there is such a thing as a big startup, to basically take poor people's money and not necessarily have any care or consideration for those folks. Maybe explain to anybody who's watching and to me as well, for my benefit, how systems can ensure equity and ensure that the lowest end of the spectrum in terms of income groups can benefit from increased private investments in healthcare.
Sure. Well, I'd be happy to do that. Good afternoon. And that's quite a provocative lead-in, but I would be happy to share my view. First of all, just to be clear, I am in my work completely private or public sector agnostic. I feel that both have an important role to play, and that the common denominator in the quest for achieving universal health coverage actually, I believe, is workforce development and deployment. And what I mean by that is that health systems around the world, both public and private sectors in those, really suffer from healthcare workforce disadvantages, both qualitatively and quantitatively. And so I was interested to read in the working paper, for example, the disparity in Pakistan between physician presence in rural versus urban areas. In the rural areas, 1 to 2,700 approximately population, and 1 to 700 in urban areas. So I think within the workforce development on the deployment side, there are actually 3 dimensions that play into this. And again, it's public and private sector equally, and that is, as I mentioned, the rural versus urban, but also I would say hospital-based versus community-based. It's clear in the COVID time that having all healthcare resources, again, either public or private, hospital-based is actually a disadvantage to both combating and controlling this kind of pandemic. And finally, there is the dimension of physical presence versus virtual. Increasingly, mobile technologies and other lower cost ways of creating presence for healthcare workers through the private sector and public sector is of increasing importance. So I hope, yeah.
Yeah, no. I'm not trying to be provocative. It's just who I am, unfortunately. And this is how I build a rapport with people. So you'll forgive me. Let me just dig a bit deeper and ask you a couple of questions about what you just said. I mean, one thing that comes out clearly from what you said is that the integration of the back end for this to work, for there to be real universal healthcare coverage in any country or any geography, any region, you need to have an integrated database of users or of citizens or customers or the potentially sick. How does it work in places that have figured this out in terms of the regulation, in terms of privacy issues? How do all of those factors play into each other? And what are some examples of where that's worked well?
Well, first, I have yet to find actually a system where it does work well. I think people all over the world are struggling with these notions of integrating disparate kinds of data as it relates to particularly community-based kinds of health status and healthcare delivery, as well as these notions of privacy. I think within that there's certainly a wide range of cultural sensitivity to privacy, and everybody struggles with that. Again, this is not really an area that I've studied in great detail, so I won't be able to provide specific examples. But from a policy standpoint, I think it's important to be able to reconcile these notions of data availability, data transferability, data ownership, and I think that usually governments are best positioned to do that in most countries.
No, clearly, thank you, and we'll come back to you, Stephen. But I wanted to set that up as kind of a challenge for you, Dr. Chaudhry. You've written this fantastic paper, which we're very proud to have been associated with and to have published. I think it sets up, hopefully, a serious conversation that goes beyond just public health expertise and explores the importance of universal health coverage. Maybe for the benefit of viewers who haven't had a chance to read the 45-page document, set us up a little bit with the changing demography of disease, and maybe that as the starting point for what inspired you to write this paper. I know there's a couple of other factors, including the issue that I think Stephen and Zena both pointed towards, which was maybe the surplus of tertiary coverage as opposed to the adequacy of primary coverage. But we'll come to that later. Just describe in some detail, if you could, what we mean when we say disease demography, and what is it that's happening in Pakistan that prompts you to be concerned about universal healthcare coverage?
Thank you very much, Musharraf and everyone. It's a pleasure to share this platform with everyone. So let me take a step back, and as Musharraf, you're saying, and ask a very basic question that I've been asking myself, is when you look at a country like Pakistan, what is the problem that we're trying to solve here? And as a healthcare expert, we look at, okay, disease is one of the key things that we are trying to address and take it and understand it better. So from that perspective, when you look at the disease demographics, for Pakistan and for similar, the trend has been noted in other developing and emerging economies as well, is that this whole notion of bringing predominantly communicable disease, waterborne disease is the issue that we're trying to solve for, is no longer true in Pakistan as well. So we need to, that changes the lens of how you look at everything, and that changes the paradigm in terms of how the policy will work and what are the solutions, and everything flows from that point onwards. So that's the biggest change that is coming, which is in line with some of the trends we are noting, where the non-communicable, the lifestyle disorders are taking a center stage as well. They have risen from peripheral issue to taking up 50% of the disease demographics as well. So when you look at these underlying issues that you're trying to solve for in a society, in a socio-political economic environment, then you need to look at the system and look at everything differently as well. And that is the impetus for writing this paper, is that we need to first understand the problem. And problem is not just of the provision, but of the disease demographics, which is the driving force. Then you look at the system and see what it is designed to do. There's a mismatch right there between them. And then you look at what can be done to address those issues and have a system that is able to not only address it in the short term, but also set the foundation for the long-term change as well, because the path to universal health coverage is not something that you achieve in 6 months, in a year or 2 years. It's a journey you embark on, and it's a journey that takes building blocks to be in place. And that's how you move forward and make progress, as other countries have shown, Thailand being a clear example. So has been the impetus for looking at Pakistan differently, and then addressing or formulating a response to that issue by way of using different frameworks that are, again, universally applicable, acceptable. The difference is how you adapt it to your local environment, because health does not exist in a vacuum. It is influenced by the social, political, economic, genetic, and other environmental issues with it as well. So it's a much broader change that needs to happen. And that's what has been the impetus for this.
I just want to, for the benefit of those that are listening, this superb paper that in many ways, even if it was just this section that I'm about to read verbatim, even if we just published this, I think it would have been a great service, because it really helps to focus in on the challenge here. You've written that you and Amara Khan, who is the co-author of the paper, you've written that the ranked 6th amongst high disease burden countries, 40% of the burden of disease in Pakistan is in the form of preventable diseases, and it is estimated that over half of all deaths can be attributed to lifestyle diseases. Infectious diseases, maternal health, and undernutrition comprise around half of the national burden of disease. Pakistan is one of 2 remaining countries on the planet where polio is still endemic. It has the 5th highest TB burden globally, with Hep B and Hep C endemic in the general population, and malaria in focal geographical areas. I mean, this is enough. Just this paragraph is enough to make your head reel. But this is not a unique story. Dr. Dilshad Ali, you've got a lot of experience, not just in the Middle East, but elsewhere as well. The situation that I've just described about Pakistan, this is a situation that represented many countries around the world, even as recently as 20 years ago. You've worked in Vietnam, and Dr. Chaudhry's just mentioned the example of Thailand, which seems to be kind of the new emerging superstar as far as COVID-19 is concerned. How did these countries get from the place that I've just described, or that rather Dr. Chaudhry and Amara Khan have described in the paper, to where they are today? What were the things that changed and enabled them to be better, essentially better places to be born and to get sick in?
Well, I think the paper defines basically one key need. You can't build a healthcare system without understanding what your population needs. And most importantly, I think base-wise, in terms of countries you mentioned, in terms of Thailand itself, and I come from Southeast Asia, my home country is Malaysia. And you need to understand what the population requires, or what the population needs in terms of healthcare interventions. So base-wise, if you're saying what do we need in terms of, before we even go into universal health coverage, first thing, of course, you're always looking at accessibility as being the key. Everybody in a country should be accessible to healthcare in any form. And for them to be accessible to healthcare, they have to be receiving the right kind of healthcare provision. And you really need to have a systemic approach towards how you would design a population health analysis that can really take up the kinds of disease profiles you have in the country. I think that's the essential point. Having a grip on what your population needs, in the case of Pakistan being 230 plus million people today, it is going to be the key into how we provide equitable healthcare to everyone. So success factors are not just basically integrating the private and public into a partnership. I think, firstly, as policymakers who have control over the country, over the nation they govern, is to understand what the needs are, and of course then create a system where these needs are met through accessible services. With regards to the universal healthcare itself, my definition of universal healthcare is very simple, and we work towards how in the early mid 20s, or in Roding 2010 2011, ASEAN as a caucus was working on equitable healthcare for everyone, and there was a race towards going into universal healthcare coverage in countries like Philippines, Indonesia, Bangkok. Of course, Thailand was the main leader in this because they had developed a system where they knew what the population health analysis was, and they knew exactly what the people wanted. Then it was countries like Malaysia who were following behind. And the main definition behind universal healthcare here is very simple, that healthcare needs to be accessible across all segments of society, where it addresses the needs of the people in terms of what the demographic distribution of each disease type is, depending on the segment they service as well. If we have that right, then we can talk about how the public and the private would work together, how insurers would come into the picture being payers, segmentizing the segment of the population that needs public funds to be dedicated towards a health care insurance program, and which population needs a subsidy but doesn't need to basically procure to public health funds in terms of getting their health care as well. So I think these are the key fundamentals that would basically define at least a baseline, a foundation into how moving forward partnerships can be built, and then a real healthcare system that's sustainable and builds towards accessibility from a model perspective.
So Dr. Dilshad, one thing that you said that I'm struck by, and it's it's a theme that obviously is for me important here in Pakistan, because there's a wider context to this debate, and that is knowing your audience, or knowing the population. It seems to reason that in a sense, a federated system of healthcare coverage, where you have policy making, standard setting, monitoring, evaluation, and research, and those kinds of functions, certainly it makes sense to have centralized. But if the purpose of public policy in healthcare is to know your population, then a more federated system in which subnational tiers of governance are the ones that are engaged with the citizenry, that would seem to make more sense. Is that consistent with the experience in the ASEAN, for example, or is it more helpful to have more centralized systems?
I think with ASEAN and even the Kingdom of Saudi Arabia, plus also some countries that are around the region, healthcare is the national agenda. You cannot disparate between a national agenda into 2 or 3 different segments which speak different languages when you're addressing the same objective. So again, central command is very important, central control in terms of policy making towards what the entire nation deserves in terms of our healthcare policy is really, really key. You then build up sub-segments into provision networks which cater towards the need. One big, I think, gap in most emerging countries or developing nations, as you call them, where the entire need analysis is not done correctly. Oversupply in some areas because it seemed to be lucrative by providers to provide for non-communicable diseases, doing more procedures, whereas less resources and less spending is distributed for communicable diseases. So really, the whole central planning mechanism is important. The equitability or the equity between the recipients of healthcare has to be clearly defined in terms of a distribution. Zones have to be created so that people would be able to procure to the ratios of healthcare and health outcome, what you call this quality outcomes are established and guaranteed in a certain way. And then, of course, the operational side and the day-to-day business can be run on a decentralized mechanism, which makes it more efficient.
Zena, you were talking about the two clusters, the North and the South, and partly it was exactly in line with what Dr. Dilshad was talking about, in the sense that you want to have an addressal of need based on a differentiation and based on an understanding of who your target audience is. In terms of the non-COVID public health system in the UAE, how does the discussion or the debate, if there is any debate on this, how does it go between people living in the same country having vastly different levels of access to public health? You mentioned insurance being a big part of it, and not just restricted to the UAE, but more widely. This is a key concern. This is kind of the thinking behind my question as I posed it to Stephen, though perhaps more provocatively than I am to you. But how do you essentially try to string together a relatively equal set of metrics in terms of minimum standards of delivery when, especially in the case of very heavy private sector involvement, as it is in Pakistan and in so many countries around the world now? What are the instruments or mechanisms available to equalize access?
I don't know that it's something right off the shelf, and I agree with everyone else that everybody has to do it based on what their own country needs are and what their own population needs are. So in smaller countries, and the UAE is a smaller country compared to Saudi Arabia or Pakistan or anywhere else, it is done a little bit easier, where you could actually do an assessment of your population that you're serving. You could do it through your insurance companies, that we're providing you insurance and what we call their members, and you can assess those members as far as what are their comorbidities and their coexisting conditions. And I think that is an equalizer. And when you find out what are the chronic diseases, not only communicable disease, but more like chronic disease, how are we doing with diabetes, heart disease, things that are common to everyone and that everyone would need to treat. And then you turn those into primary care and the primary care and preventive care. So if everyone gets the same preventive care and primary care, that's an equalizer for all populations. And then tertiary care and access to other sort of specialty care, if you want, could be stratified through insurance networks and through different levels of insurances. But I think if we do preventive and primary care right, I think you get a handle on most of the population, if not all the population. And then from there, you sort of build tiers based on what your demographics are as far as chronic disease, not just where people are from, but and their socioeconomic class, but also what disease does that population have versus another population. So in the Middle East, for example, diabetes and cardiac disease is prevalent. So what are the systems that you can build around those chronic diseases to sort of prevent coming to the ER, prevent the visits to the hospital before they even happen, and spend the money on preventive care and cover vaccines. For example, have insurance plans that agree to cover vaccines, agree to cover prenatal care, or screening for heart disease and for diabetes. I think you find that you will cover a lot more population. You'll equalize it, as you say, and then from there you build networks and systems that could address the smaller group of patients or of people that become patients in tertiary care and in secondary and tertiary care.
So it really aligns really well with a lot of the discussions that I had with Dr. Chaudhry as we were developing, the structure for this paper. My suspicion is that, like maybe Stephen alluded to, there isn't really any country or system that's figured it out fully. But again, I'm sort of, thinking about the big gap here, and the big gap on preventive health care is really a communication gap, is it not? Are there examples of where a robust preventive healthcare strategy for, let's say, diabetes has successfully reduced the consumption patterns that tend to lead towards diabetes? The best example, of course, globally is cigarette smoking and lung cancer. But I'm not sure that the pushback was a public health pushback. Like, I don't think it was a group of the five of you or people like you that came up with the anti-tobacco thing, right? Which is fine, because we know that a lot of families of victims of lung cancer were the ones that took class action lawsuits. There was a lot of tort and there was a lot of legal sort of machination rather than a public health response. So I guess the question I'm asking is, what does it look like to have a robust public health preventative response to disease? Again, COVID-19, you have good examples and bad examples, but in terms of some of those other chronic diseases, it seems like there's very little to choose from. Sorry, you got to unmute again.
I agree. There is very little to choose from. I can't think off the top of my head of a system that worked well. In the US, maybe we've done it better, and Steve would know how to answer that better than I would. But I think there are diabetic centers that have done well. There are sort of semi-governmental agencies that have helped, the ADA, for example, and other things that have put guidelines out there and made them public and help people. But again, it's also a personal choice. So there is also a little bit of how much public health can you do without invading people's private choices and public choices. So you start with education, and that has worked well, but that can only carry you so far until a personal choice is made. It's
interesting you mentioned the private choice aspect, because of course with the use of masks, that's become a big, almost this big sort of First Amendment thing, right? Like, I don't want to wear a mask because there's a lot of, for lack of a better term, there's a lot of Karen rage, especially we see in sort of the Dust Bowl and the Corn Belt and the Rust Belt in the U.S., but certainly even in places like New York State. Stephen, maybe I can ask you this question about this freedom agenda. We have examples of, for me, the most accessible one is New York City, where they started with they were kind of early adopters of a ban on smoking, just a blanket ban on smoking in facilities where lots of people meet, like bars and lounges and the sort. We also had fizzy drinks being banned in public schools, and there's a whole series of kind of progressive, but also freedom restricting public policy measures that are essentially, at least in my view, public health measures. The downside is that there are private sector entities like the manufacturers of sugary drinks that push back on this. How does this balance get played out over the long term, and how can private sector businesses, venture capital firms, benefit from a more robust engagement on preventative public health?
Sure. Okay. I think that's a very important question, and I think for the sake of this discussion and the prior questions as well, I think it's important for everyone to distinguish between public health and healthcare delivery. We're sort of flipping back and forth in the way that we think about it or the way that we talk about it, because it is generally the purview, and to answer your question, I think it certainly is the purview of the public sector and governments to work to develop the policies related to both the identification and the remediation for public health issues like obesity, smoking-related diseases, diabetes, that sort of thing. And I think that, to your question, I think that the resolution or the solution set that comes to a lot of these stated public health problems and the epidemiology associated with it are private sector or can be private sector driven. I think that, for example, in the case of diabetes, one of the big issues is related to food availability, proper food availability and nutrition. And I think governments, particularly local governments and municipalities, working with food distributors to address the so-called food desert phenomenon that exists, particularly in urban areas, is an example of private sector working with the government through the resolution of a stated public health issue.
Thanks, Stephen. Sada, when we think about how these issues will play out here in Pakistan, I get a little bit skeptical, and a lot of my questions are really rooted in this almost sense of disbelief. How do we get from where we are, and you're more familiar with that than I am in terms of public health provision in this country, to this notion of universal health care? Part of the reason why I'm framing the questions in the way that I am is that, you know, serious people who are part of the audience will have the same skepticism. They will think, look, we struggled with a mini peak. You know, I don't know if COVID-19 has fully peaked. I do think there was a mini peak post-Eid, and it was a nightmare to have to watch the pictures of or speak to healthcare providers in large cities, in some of the bigger hospitals, Peshawar, Lahore, Islamabad, Karachi. We saw some very scary scenes. They were the beginnings of some of the stuff that we saw that happened in Italy. When we juxtapose this reality with the vision of universal healthcare coverage, you know, I've tried to outline or highlight a few of the issues. We have a federalism issue where there is a debate about what the best place for delivery is versus what the best place for planning is. I think Dr. Dilshad has masterfully responded to that. You need to have policy and standards central, but you need to have delivery as federated as it needs to be, given what system you're in. We've tried to raise the question around public-private partnership, and what that actually means is just a vehicle for more profit for private sector organizations. An associated question that isn't so much a challenge maybe in the ASEAN or the GCC, but is certainly a challenge here, is how you guarantee against quacks, because for every private sector actor, you will have private sector actors who are malign and who can get away with doing bad things. Finally, this question around the provision of preventative public health, and especially communications campaigns that enable a more robust response to communicable and chronic diseases. Again, from the vantage point that you're at, where you're trying to build communities of healthcare providers, what is the quantum of challenges that your people face in terms of queries and requests and demand? Is it more on the communicable side, or is there more of a challenge on the chronic side? Sarah, you'll have to unmute. Thank you.
So I think I'll second to Dr. Dilshad's point. I think he was absolutely right, and I think one way that Pakistan has not been able to create a very robust healthcare system or move towards universal healthcare is because after devolution, the policy making is in the hand of province rather than one central command and control center. And that's why every province in Pakistan, and there are 5 main, and they move towards their own policies, and then and then they monitor and they regulate and they implement, and they are the service delivery providers. When working in public healthcare in Pakistan, being a public health enthusiast myself, I see that Pakistan, on paper, in principle, has a very nice healthcare system based out. So there's a primary healthcare unit, which is the basic healthcare unit, and then there's a secondary healthcare, which is the rural healthcare unit, tehsil healthcare unit, and all the way to the tertiary healthcare center. And it is made with the vision that whenever someone is sick in a community, they can go to a basic health unit, and from there they are diverted into these segments of healthcare centers, and they can reach a tertiary care center where everyone in the chain knows about their problem. I think why the issue comes out is none of this is practiced in Pakistan in the way as it's written on the paper. Even if we talk about basic to primary healthcare, there are around 95,000 lady health workers or community health workers or community midwives that are created time to time in different governments from the history when Pakistan was created to cater to the basic primary healthcare needs or maternal child healthcare needs or fertility needs of women who are the most vulnerable in the country where it comes to healthcare. But none of them have been able to provide their services as they had to. And a lot of things come into that. One, I think the most promising, which is something that I work on, is the majority of the healthcare workforce in the country being female doesn't practice. So that increases the gap between the doctor to patient scenario. So we have very less doctors. According to the patients that we have in the country, we have one doctor for 1,300 people, which is where the problem begins. And in order to cater that, the lady health workers or the community midwives who are created in the country are not providing services as they had to because of the lack of capacity. So one, I think we see a lack of doctor shortage or a qualified healthcare shortage. But even more than that, I see a lack and a very big gap when it comes to the capacity of the peripheral healthcare workers that were created to somehow cater the gap of doctors. So nurses, dispensers, technicians, all of them who are working in small hospitals or small communities or provide healthcare in small villages, they don't have the capacity to cater to anything beyond. So even something as in small history taking or clinical examination, anything which is very basic in identifying symptoms to a patient is not possible for these nurses or these community health workers even till date. And that somehow increases the load of healthcare burden all over Pakistan. In my work, I've seen that majority of the medical healthcare issues that people come to for us on a telemedicine platforms are very basic primary healthcare issues. And they come to us because in their communities or in their villages or in their networks, that quack or that doctor or that nurse who's sitting is not able to identify their primary care issues. When that doesn't happen, ultimately, if they don't find it in their community, they'll land up into a tertiary care provider hospital, increasing the load on tertiary healthcare, which is overburdened with a lot of patients. And that's why quality doesn't happen in tertiary care spaces. So if I had to give my 2 cents of universal healthcare coverage, I would start from primary healthcare. And we already have the infrastructure in place. The 2 things that we do need to work on is the peripheral healthcare network that we've created over time, which is a huge resource that we can use, building their capacity, bringing them up to date with new knowledge, with new learning protocols, with new medical protocols, and making doctors available in the basic health units, or at least making some sort of delivery service available in basic health units. A very big phenomena to do that is through telemedicine, which is something that I work on, is how you can create doctors virtually, if not physically. And I think that again calls for government recognizing digital transformation and maybe moving towards it.
So I think clearly, there's a meeting of minds between sort of what you're saying and Amara Khan and Dr. Muhammad Ali Chaudhry. Dr. Chaudhry, you've in a sense laid out a coherent transformation roadmap that aligns quite nicely with what Dr. Sara Saeed has just described. And you have in it, I think, kind of essentially 6 key pillars for this transformation. You talk about service delivery, financing, capacity enhancement, public policy and leadership, public policy and legislation, governance and leadership, and finally, what Sara was talking about, which is digital transformation. Again, I would say, I tend to err on the side of skepticism when it comes to something as grandiose as this transformation roadmap. You've already said that these transformations take a long time. I hate to do this because it's such a thoughtful and well thought out paper. But for the benefit of the conversation, I think the question has to be asked: if you had to choose just one of these 6 areas, somebody's put a gun to your head and said, we don't have any money or any political will whatsoever, but we can go all in on one thing and we will truly deliver this one thing out of these 6, what would you end up choosing?
So thank you. Let me just frame my answer to this.
It's kind of you to say thank you. maybe a question that isn't very fair.
No, it is a fair question because look, this is one of the things I asked myself when we were writing this, that the solutions we provide should not be again the run-of-the-mill solutions that spend more, find more people to do this, and those generic solutions that you find in every other document. And that's not what I wanted to do. And when you look at the paper and look at the solutions, I don't think so anywhere we have mentioned no, government has to spend more because we are not doing enough. First and foremost thing I said, reorganize is what's needed. Reorganization is you look at the problem, look at what the existing infrastructure is, and there is a clear mismatch, which does not mean that whether you're spending $1 or $10, it'll go to waste because there's a mismatch in between what the problem is and what the solution is on the ground. So that's where you have to reorganize it first before you even start thinking about spending more money into it. So that's one thing. Second is, as we are seeing now, the changes in the demographics, the focus should be shifting from just focusing solely on curative to preventive and promotive as well. That's the second aspect. And the third one is where I had the notion of investments and private sector and so forth also getting involved, is that instead of government keep trying to spend more and more, there are so many opportunities where governments can play a role in creating a policy that supports private sector to come in. And let me just address that before I pinpointly answer your question. Is this notion of private sector or private healthcare in Pakistan having a stigma around it? 70% is already private. Everyone's paying. 70% of people are paying out of pocket. Only 1% of the GDP is spent by the government. 2% comes from the private citizens of the country. So it is already in that shape or form. So we need to differentiate, as Steve said, that when it means private, it does not mean that the whole health system is privatized. And this notion of the boundary between public and private has changed over time. Even the public systems, wherever you go, whether it's the Western European ones or America, or if you go to the Far East, even if they are centrally driven in public healthcare systems, they look for private sector efficiencies in those systems as well. So we need to leverage those efficiencies and we need to build into those as well. So that's why when you look at all these things, putting it together, the reorganization of the system is the first and the foremost thing before I go anywhere by spending more money or by trying to change, building new facilities. There is already an infrastructure on the ground. We need to first look at that and utilize it properly before we move on. And in that context, there is enough room in all those 6 pillars where you can have human capacity development, where you can have quality measures put in place, where you can have the governance and leadership development and intersectoral involvement on the ground as well. And the impact of COVID in this planning is digital transformation. That needs to be pushed forward, which makes it cost effective to expand your access across board using the same infrastructure that's already on the ground. So that's why for me, changing the playing field, the way it is designed at the moment is the first and the foremost thing, and the lens has to change. Change that lens, everything else will start looking differently then. This whole notion of archaic primary care being boring and being publicly driven, inefficient, it's because the way it was designed to serve that purpose. That underlying phenomena has changed, so we need to look at it differently. So for me, the lens has to change, and that lens most likely will be in the public policy and legislation aspect. And that is where I define that the government has to really think that what is their role in the provision in the whole healthcare system. Are they going to be a provider? Are they going to be a regulatory body? Are they going to be an accreditation body, or what? And as Dr. Dilshad rightly said, the planning, which is being the shepherd of the healthcare in a country, which is a basic right that has to be provided, the government has to clearly define their role and be very specific in terms of how they're going to define the boundaries in which and create a level playing field for everyone to come. And that's where government can build protection mechanism for the marginal societies, where they can build protection for the elderly, where they can build protection for other segments of the population that are susceptible to other pressures. And then also leverage the private sector, which already present 70% in the country, to develop a program and develop a system that is able to cater to the needs. And what I meant by that universal healthcare is a long process, but it has to start somewhere. And it has to have short-term things to be put in place before we aim for 100% universal health coverage. And that's why these building blocks, that's why we put it in phases, that what can be done now without anything. For example, putting a quality system or using the quality standards that are already present in some shape or form, aligning it with international standards and rolling it out across the country. It does not require a heavy investment, but that's the role of the government. The government becomes smart about how they're spending the money and what their role is, and I think they can benefit a lot more from the same amount of dollar they're spending before they even think about allocating more resources to that. Because according to World Bank estimates, the inefficiencies in the system, in the public system, range anywhere from 20 to 40%. That's where government can leverage private sector to build those efficiencies. So this is what I think, and that's where we have created a roadmap to move forward, which includes short-term, mid-term, and long-term changes that are going to take effect. And I think the key in all of this, whether it's policy or health delivery system or financing or developing human capacity, agility is the key. We thought that life will be okay pre-COVID, everything is moving forward. We have enough time to make changes. It just changed overnight into something we never anticipated. So can you forecast and foresee all these challenges across the board? No. What you can do is you can build a system that is agile, embedded in the community, serves as the center of the community, creates an economic activity, have the buy-in from the society, which helps you respond better in any situation that will come your way, instead of just focusing on another policy that is going to prepare for next pandemic, which we don't know how and when and what scale would it be. Long answer to the question.
Well, no, it's fine. I think the whole purpose is to hear you talk about this, and to get the take of the other experts that are on the conversation. So and that's why we have these longish sort of panels rather than trying to get sound bites from everyone. We really want to dig in. I want to go back to Stephen because obviously I've been quite assertive about this idea of private sector incentives, certainly often perhaps skewing the picture. But we don't, when we blame the private sector for that, we often don't concurrently openly speak of the problem on the public sector side, which is that the reason why Dr. Chaudhary has to identify reorganization and reprioritization, the reason why there's an underemphasis on primary healthcare is because there are also skewed incentives from the political perspective. It is politically more beneficial, at least in the context here in Pakistan, for ministers or politicians, prime ministers, whoever is in charge, to stand in front of a crowd and say, we're going to build a new heart care, like a cardiac center, or we're going to build a new kidney surgery center, or we're going to build a new, all these kind of tertiary centers. And once these announcements get made, there's a whole slew of private sector interests that then converge. So it isn't just that there's a bad guy called the private sector that's out there to make money. It's that the private sector incentives are being buoyed and delivered in a sense by bad politics. The reason I bring this up is that the proposal to reorganize and reprioritize seems distant in terms of achievability, because whilst we can work with the private sector to identify areas of profitability in any scenario, how do we get politicians to essentially be less interested in votes, which is really what's driving some of this behavior?
Sure. Well, again, another big question, but I guess I would reflect a little bit on Dr. Chaudhry's point about, I think that government as a whole needs to be clear on its position. I think that in cases where we see the most effective public-private sectors working together is when the government actually gets out of being a provider, that it is the policy arm and the regulatory arm. And I think that that necessarily then moves some of these incentives for, kind of big government projects that maybe don't address the needs of the populace. So I think that getting government out of being a provider, I think clears the path to the point that you're making about decision making for votes as opposed to decision making for the public good. With that, I just if I could. Back to how you started your question to Dr. Chaudhry, if you moved the gun from his head to mine, as I read the paper, I think it struck me that I would work all in on the healthcare workforce development. There have been several comments about I'm repeating a little bit of what I said earlier about this rural versus urban availability of the workforce, about hospital versus BHU or community-based healthcare providers, and then this physical presence versus virtual through digitalization. I think that the key to moving to the primary care component development really is through this workforce development.
Say a little more about that. I mean, we have I think now universally in the BHUs, and Dr. Sada, you could correct me if I'm wrong here, but I think every BHU has at least one doctor. One of the challenges here is that in a lot of the, I have to frame this carefully because it's become extremely politicized, the conversation about doctors writ large. We have professional associations, for lack of a better term, trade unions that doctors belong to, that make the newspapers rather suddenly, abruptly, but quite frequently based on service conditions like salaries and permanence of tenure and those sorts of things. When you have the politicization of the profession in the way that you have had here, and I don't hold that against the doctors, because the doctors themselves have been thrown to the wolves. They've been left in many cases in BHUs that don't have other facilities, oftentimes at the mercy of communities who get very upset if somebody dies on their watch or somebody is badly hurt. It's a very weird combination of cultural factors and capacity factors that restrict the ability of doctors to actually deliver at the BHU. When you say workforce capacity, I'm thinking you mean more people with better qualifications, or do you mean something more complicated?
No, I actually, you'll note that I didn't use the word doctor workforce development. Actually, I think that the way to enhance the healthcare delivery system is through the development of a workforce that has more skilled workers at every level, not just physicians, but most predominantly nurses and other technical staff that can actually help to make the physician's the physician capabilities or the physician's capacity even more expanded. I would say that there's a great opportunity when we look at other more developed primary care systems that actually the variety of care, or the majority of care, is not provided by physicians. It's provided by nurses and other paraprofessionals that are working at the community level, and then work closely with physicians when their skill set is required.
Okay, so that's a fantastic segue into a question I had for Zeina, which was about workforce development in terms of nursing. With your experience, to what extent system-wide does it change the dynamic to have more capacitated nurses? One of the biggest challenges here in Pakistan is fully qualified and certified nurses. Even though we have quite a large, not inadequate, but quite a large population of doctors, our nurse population, especially with the requisite sort of globally acceptable certification is quite limited. You've been involved in efforts to beef up nursing capacity. What share of the problem does it help address at a system-wide level?
At a system-wide level, it helps, I think, address a big part of the problem. So there's a common term you will hear is, are nurses practicing, or any healthcare professional practicing to the top of their license, which means they're licensed to practice nursing, but are they truly practicing to the best of their abilities or to the best of their education? And there's different levels of licensing. So the first thing you want to do in any place or any country is standardize the licensing process and make sure that who you're calling a nurse has certain expectations and has had a certain education and training to be called a registered nurse versus a non-registered nurse or a licensed nurse, practical nurse. Or it depends on where you are in the world, that they have different nomenclature. And then some parts of the world use midwives, and they're very, very instrumental. And some parts don't. So the first thing you want to do is look at your nursing workforce and look at the levels of nursing and the education that they receive. Are they educated a 4-year education, 3-year, 2-year? There's different types. And unfortunately, the disservice in nursing is they're all called nurses, and they're not all performing the same job and at the same level. So once you standardize that and sort of license people properly, and then have a sort of practice act or a scope of practice that they could work under, then it is well known to everybody what each and everyone can and cannot do, and then how they can be best utilized. Can they be utilized in primary care and in secondary care? Can they be utilized in ICUs versus ORs and so on? So I think the first thing to do is assess your workforce that's available through your schools or through available nursing schools. What systems have they gone? What's the curriculum like? And so on. And then actually build that workforce at a bachelor's level. And then you could decide, what is your entry level to the profession? And in Saudi, for example, we worked very hard to get it to be a bachelor's only. We worked very hard in the US to get there as well. It took a few years. And then that way you standardize the care, and then from there on, you build nursing leaders. And, that after that, you could specialize as nurse practitioners, as anesthetists, and that will depend on what the country needs or where you are needs. But the primary thing to do is get your basic, and I don't mean that in a disparaging term, but the basic nursing nursing workforce met, and then that once that need is met, you could build upon it and create leaders and create nursing professors and researchers and so on. But the bedside is where you want to focus first, to create that public awareness of what a nurse does, how it's licensed, and then go from there. But it takes a little while, but it's not, we were able to reshape it in so many years, and it takes both a private and government effort. Schools are of all kinds, and it takes an effort at the academic and as well as the service sector.
I guess the reason to go on, Dr. Khoury Stevens, is that we have a challenge in terms of, first of all, aligning policy and getting political will at the top of the mountain aligned with this vision. And then you have to align the schools and the instruments of capacitation aligned. And then you actually have to produce the human resource output that needs to be produced. So obviously that's not several months, that's probably a several years journey. Dr. Sara Saeed, what is your view on this? How far do you think we are from being able to say that we've at least started that journey here in Pakistan, especially on something like nursing? I think we're terribly undercapacitated and we're nowhere near setting out on that journey. But I'd love to be corrected if that's an incorrect assessment. You'll have to unmute. Thanks.
No, I think I would second that. We have a huge problem and shortage of nurses in our country. And also, I think to your previous point, even in basic health units, all basic health units are not equipped with doctors. Even in the basic health units that are present in the cities, we often find that Doctors are not present in BHUs. But coming on the point of the nurses, I think one thing that I've seen in my practice, because I've had the experience of training about 2,000 to 3,000 peripheral healthcare providers in the course of our work. When we provide them telemedicine tools, we do train them. And I've realized that there's a huge problem of education specialists and trainers in the country. A lot of programs are being run for different levels of nursing. So in Pakistan, there might be less number of nurses, but there's a huge number of midwives and community midwives and lady health visitors and lady health workers that are women that are trained to provide basic reproductive health care in the country. And when we start to train them, we realize that they lack in even their basic capacity to understand any illness or any disease. And that is because infrastructure is present, but trainers or curriculum or the education quality being provided to them. And majority of these are trained by the government. There are very, very little private providers who train peripheral health workers in the country, with the exception of few, such as Khan. So I think one thing that I've seen in my practice is there's a huge lack of trainers and educators who can actually train them, and also refresher courses and the incentive for them to come back and to relearn, because protocols and procedures change, researches and guidelines change, but we're still using the same researches and guidelines that were present 30 years ago for nurses and midwives as we're doing it today. So that also calls with a rapid change.
Do you think COVID, I'm sorry, do you think the COVID-19 epidemic is going to help update those protocols and maybe represents a window of opportunity for a sea change in protocols in healthcare here in Pakistan?
I think what I've seen is I don't really have seen a massive uptake in new researches and protocols when it comes to peripheral healthcare workers or primary healthcare. A lot of it has to do with COVID. What I have seen is, and if I had to take that hat and put it on myself, just one transformation, I would really vouch for digital transformation, because I've seen that government has adapted in these last 6 months and an opportunity to take courses and train peripheral healthcare workers, doctors, because we lack in critical care intensivists also. Pakistan has less than 100 intensivists in the country who can actually help critical COVID patients. So in order to adapt to that, I've seen that the government has made tutorials and courses that were given over very, very simple programs to nurses and doctors. And I've seen how virtually a huge mass of nurses and doctors are being trained in the country for primary COVID health protocols, for critical care scenarios. When a nurse sees a patient of COVID, how does she react? How does she connect to a senior doctor and then connect to a consultant and then connect to a critical care specialist? I've seen that change coming on by the government at a federal level. So I do vouch that digital transformation, whether it's in education, whether it's in data collection, how we enable smaller hospitals in the country, their EMRs to be connected to tertiary care hospitals, or when it comes to virtual presence of more doctors and nurses and connecting to each other as well as to the patient virtually, I do see a very big potential of change, and for us to rapidly escape a lot of points escape a lot of steps that we are not doing so far and come at par with other countries. I see digital transformation playing a huge role in that.
Sorry, Dr. Dilshad, maybe we'll go to Dr. Chaudhry for the conclusion, but I just wanted to bring it to you, and I'm going to ask you to help me be a little bit more optimistic. This journey that we've outlined seems to be a very, very long one. You talked earlier about your home country in Malaysia. We made references to Thailand. I think Vietnam is being celebrated. So is South Korea. Again, I would say the human capacity, the workforce capacity issue in these countries used to exist. What was that journey like? How long did it take? And how long, if Pakistan decides that COVID is the trigger to get on this track and to follow the advice and the leadership of somebody like Dr. Muhammad Ali Chaudhry, how long do you think this journey would take? How long did it take in other cases? And how hopeful are you that it's possible?
Well, I think, Musharraf, the first point is back to Dr. Chaudhry's point about policy and leadership. The time is not the whole measurement behind how the success factors work, because every country had their journey. And if you look comparatively between all the countries that you mentioned, they are all at different stages of maturity and really the response to COVID is not a measurement of how successful they were in terms of deploying their healthcare systems. Because, if you compare between Vietnam and you compare South Korea and you compare Thailand, you'll see 3 different models of how healthcare is being managed and how health education works and how healthcare workers are empowered and educated. So I think defining a timeline is not going to be fair, because that's not going to be really the absolute measurement of how successful it is in terms of deploying the model. Most importantly is still the policymakers. They have to basically have the will to really bite the political bullet and say, look, it's not just about politics, it's about the future of our nation, and it's about how people would be well and we serve them as the rulers or as people who manage this country towards giving them accessible healthcare. Then, of course, comes in the leadership and the integration. But I think just one point before I quickly sum up and get Dr. Chaudhry to give his summary. We've spoken a lot about patient systems and policies and leaders. One real strong aspect behind how successful your universal healthcare systems are going to work is empowering patients themselves. And I think I'm going to leave this as food of thought, that if your patients are not empowered to look after their own healthcare and they're not educated towards what their own responsibilities in terms of managing themselves and their healthcare profiles, no matter what program you put in place, there's still going to be a missing link towards a success factor.
Well, thank you for that. I think that sets an agenda that is much wider and deeper than public health, but it's absolutely the correct sort of note for you to end on, Dr. Dilshad. Dr. Chaudhry, it's a fantastic, as I said, a fantastic effort, and super proud of the work that you've done. But having been part of this discussion and heard these views, where do we go from here? It seems to me that each one of those 6 pillars that you've defined merits a new working paper in and of itself. So I suppose I'm going to use this opportunity to get you to commit to partnering with various people on this panel, but also beyond this panel, especially folks that have worked here on public health in Pakistan, with whom we plan on doing another session just for a more localized version of this conversation. I think we need at least 6 or 7 more working papers out of you. What do you think?
So, you're rightly saying, because this is a roadmap that gives you a direction, it gives you a boundary to start thinking about within those boundaries, which is aligned with what we have reiterated and we have said, that once the agenda is set and once the boundaries are defined, then you can have a deeper conversation, deeper dives into each vertical or element and build what is needed. And that will also be driven by what are the local environments, the local engagement. So this is a process which goes much deeper, but defining the pillars of what we need to focus on and giving a sense of direction in terms of what are the things that can be done in the short term while we are looking at the system and changing the foundation of the system for the long term. These are the things that needs to be done. So it's a macro changes, it's the micro changes which will ultimately make it sustainable, will be anchored in the community it serves, because they will be a part of it. And that's why the angle of serving as an economic stimulus for the community, whether it's in the form of better health, whether it's in the form of better employment, whether it's in the form of local engagement, you will have a change that will spread across over and over again. So that's why it's important. And I agree that, all 6 pillars are papers and policies of its own, which will take a life of its own once we have set the agenda right.
Dr. Chaudhry, thank you for everything, and especially for helping convene this fantastic group. Stephen, it's been a real pleasure, and I'm so grateful for your insights and your thoughts. Dr. Sara, believe me, we will be in touch. I think that a lot more work needs to be done on this. I think that the way you speak about the issues, the way Dr. Chaudhry speaks about the issues, there's a lot of synergies there. So inshallah, we're gonna invite the 2 of you and many others to synergize and work on these issues. Zaina Khoury Stevens, what an absolute pleasure. And I think that both you and Dr. Dilshad Ali, under better circumstances, it would be nice to have you here in Pakistan to assess and examine what is happening here. For the Hajj season, Dr. Dilshad Ali, a special prayer and and warm wishes to you and to Dr. Chaudhary as you manage that really intense experience. And to all of you, a very happy upcoming week. Thanks once again for joining us. Look forward to having you on again very soon. Thanks, everyone.
Thank you.
Thank you.
Thank you.